We're taking this, 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 we're taking with a pinch of salt.
Dear ladies and gentlemen, welcome to another episode of A Pinch of Salt. I've been really excited about doing this episode for a long time now because I believe this topic really deserves more exposure. Today we'll be talking about tubulointerstitial nephritis, TIN or TIN for short, a tricky condition that I believe one could define as the Cinderella of nephrology. That is to say that it's beautiful and an interesting topic that nobody seems to notice or appreciate very much. Now, of course, that's not entirely true. There are some princes who notice the Cinderella of tin and appreciate its complexity, but certainly in terms of webinars and sessions on major congresses and so on, you usually have to find something tin related with a magnifying glass. Particularly if you compare this to glomerular diseases, tubulointerstitial diseases seem to be almost forgotten. In an effort to correct this anomaly, we have invited Beatriz Sanchez Alamo to talk about tin and what's new in this field. Beatriz presented this topic at the last ERA Congress in Vienna, and she's also been involved in some very cool papers on tubulointerstitial nephritis. So, Beatriz, thank you for joining us today, and welcome to A Pinch of Salt.
Thank you, Andre, for this kind introduction, and thank you to the ERA for having me today. It's a pleasure for me.
Yeah, I'm really excited to hear what you have to say about tubulointerstitial nephritis. So I've made the argument in the beginning, but I'll ask you whether you feel the same way. So just to provide a kind of backdrop to this, some recent data looking at long-term prognosis has shown that patients with tubulointerstitial nephritis experience end-stage kidney disease in about 30%, which is similar or even worse than contemporary data for lupus nephritis and ANCA vasculitis, two diseases that we're all kind of scared of in terms of their kidney-destroying capabilities. So do you believe, as I do, that we are ignoring tin? And if so, what should we be doing differently?
Yeah, thank you for your question. Indeed, I fully agree with the title of this talk, which is the Cinderella of all the nephrology. Tin has been neglected during many years because it was considered as a mild form of kidney disease. It is true that it is not as abrupt as other kidney diseases, such as, for example, AAV. Indeed, this disease, in many cases, the symptoms of the disease are mild and they are non-specific, but the disease can also be completely asymptomatic. The only manifestation, perhaps, is only an acute kidney injury, which is classically non-oliguric. And indeed, regarding drug-induced acute interstitial nephritis, there were some series in the literature emphasized that the diagnostic importance of the classic triad that you perhaps may know, the fever, rash, and eosinophilia. However, we know now that fewer than 10% of all the cases will present with these three features. For me, I think that to change things, one important step is to raise awareness of the disease, both for the general population and for the clinicians. Because many drugs, such as, for example, the proton pump inhibitors, are considered as being safe, and they can still cause adverse events. For clinicians, I think that the most important thing is to maintain a high index of suspicion, and because the early recognition of this entity allows timely diagnosis and the treatment. However, this can be really challenging because, for example, in those cases involving these proton pump inhibitors or the immune checkpoint inhibitors, the temporal relationships between the exposure to the drug and the onset of symptoms is unclear, and the classical manifestations may be absent as well. For example, in the case of proton pump inhibitors, the presentation is really non-specific, and the interval between the use of the drugs and the onset of the disease can really range from 1 week to even 9 months. So this makes, as you can imagine, the diagnosis more difficult and, of course, requires a high index of suspicion. On top of that, I think that there is no established or any invasive test non-invasive test, sorry, to determine the cause of this acute kidney injury. Because, for example, as you mentioned, for AAV, there we have ANCAs or we have anti-DNA antibodies for lupus. But in this case, there are not well-established procedures apart from the kidney biopsy to determine which is the disease.
Exactly. Yeah. So I guess having a low threshold for a biopsy, because the biopsy is the one that really diagnoses it in patients with unexplained bad kidney function and low-grade proteinuria, that's certainly important. And then the interpretation of the drug, that's a nightmare, as you said. And maybe if we touch upon that, because we physicians, we often are easily satisfied with an explanation, like, okay, it's PPIs, he's taking PPIs, but are we sure? I mean, saying that somebody can't take PPIs anymore in their life can be a very tricky thing. Somebody, you might have an ulcer or a gastric ulcer, and that would make things really complicated. So now at least, and finally, we have some tests where we can actually prove that this might be drug related. Can you explain something about that? You explained that at the Vienna Congress very nicely. Can you tell us something about ELISpot and lymphocyte transformation tests so we can finally be certain, yes, it's this drug that's causing it?
Yeah, I'm really passionate about this new test because I think it can really change everything, as you mentioned. For example, for some patients that cannot receive PPIs or even NSAIDs anymore, it's a nightmare for them. Even if they, for example, if they have some pain, it's a nightmare. So one of the most promising tools that I would like to bring you today is the lymphocyte transformation test. This assay evaluates the proliferation of lymphocytes in response to the pure form of the suspected drug causing the disease. And it is based on the activation and expansion of drug-specific memory T cells after incubating the patient's peripheral blood mononuclear cells with the drug. So the procedure easily begins with a blood sample from the patients, and then you should isolate the PBMCs by centrifugation, and you culture the cells. So then when you have this done, you add to this culture the suspected drug, and you incubate both things for 5 days. After that, you add timidine, and which is radiolabeled, which is the most important thing here, and you incubate this for 10 to 16 hours. This timidine will be incorporated into the DNA of the proliferating cells, and it will allow the quantifications of T cells, because you will measure, thanks to this assay, the levels of radioactivity in the samples. So in essence, very basically saying, the test will measure the degree of T cell proliferations in response to the drugs. So when you have a lot of cells proliferated, because you have added one specific drug, then you know which is the causative agent. Unfortunately, this test is only available in some centers. And for example, I have read through very important and very beautiful cases in which they have reported that it has been really helpful to distinguish cases of acute interstitial nephritis induced by beta-lactams antibiotics and, for example, a non-steroidal anti-inflammatory drugs. Another case that I have read through is a case in which a patient was treated both with nivolumab and lansoprazole. And with this assay, we knew that the patient was reactive only to lansoprazole. So the patient could still receive nivolumab, which is really important for these patients that have been treated for a cancer.
Yeah, definitely. Or maybe you could also probably try another PPI, and if the patient is not reactive, use that for treatment, I guess. So this is sort of like a quantiferon test in a way, like we have for tuberculosis, where you measure interferon gamma when you give antigens to lymphocytes, but in this case, it's a timidin test, so it's similar to quantiferon, as I understand it. So you have this test in Madrid, I expect. Is that true?
Yes, in some centers we have this test, and in fact, the allergologists have been using this test for ages. It's quite well established, but for us, for nephrologists, we are not that aware of this test. And unfortunately, it's not available in all of the centers in Madrid. But perhaps if we could raise awareness and talk to our colleagues, the allergologists, we could have this test more available.
Yeah. So we might talk to our own labs and discuss whether they may be able to do this themselves, right? So this could become widespread in Europe, if I
Exactly.
understand
I
you
really
correctly.
hope it.
Okay, okay. Very, very, very interesting information. I think that could be really life-saving, well, at least stress-saving for nephrologists and for patients. One other tricky part about tin is how you treat it and for how long and how you monitor the treatment and so on. So currently we treat most cases with steroids. Are there data that outcomes are better if you give it early in the course of disease? Because that's always the question is how quickly do you perform a biopsy, right? Because if the treatment is better earlier on, do you have to hurry with the biopsy? Are there any data that the treatment is more successful when you give it early?
Yeah, thank you for your question. I mean, there were some cases in the literature reporting that corticosteroids didn't add much to the treatment, but the group from Madrid and also some other papers take into the conclusion that the problem was the time, that the key to achieving better outcomes was the early initiation of corticosteroid therapy. But what I would like to stress is that the first step is always to stop the possible causative agent. And if there is not recovery within perhaps 5 days, we could say, then it's time to start glucocorticosteroids. However, there is not enough evidence to favor intravenous or oral corticosteroids because both are considered equally effective. Personally, I would recommend intravenous steroids like 3 pulses of methylprednisolone only for the most severe cases. And I would be especially cautious with patients with diabetes, a story of osteoporosis, or frail elderly patients. And for most of the patients, the recommended oral prednisone dose is 0.8 to 1 milligram per kilogram per day. And you should monitor your patient during the first week. And if your patient shows a complete renal response, we start tapering by 10 milligrams per week until we reach 10 milligrams per day. And then we pursue tapering by 5 milligrams per week, until discontinuation. If we obtain a complete response, we maintain the same dose for another 2 weeks, and then we taper gradually. I think that for some of the published series that I have read through, the optimal length of the therapy should take around 8 weeks and no more than that. For some patients that may be having this condition because of this ICIs, some of the clinicians say that it should be necessary to pursue with the tapering of corticosteroids for 6 to 10 weeks. And some of the series also recommend to even if you have started again with the ICI to treat a cancer, you should even keep on going with your corticosteroids for more than 2 weeks, because sometimes if not, you may have another acute kidney injury. So it may be interesting to have this into account as well.
Sure. So you mentioned that you could afford to wait for 5 days, perhaps, when you discontinue the one that you think is the offending drug, and then if not, treat with steroids. Do you always do a biopsy before you give steroids, or do you sometimes? I'm not talking about immune checkpoint inhibitors. That's a different story because there it's so typical. But in other cases, do you always do a biopsy, or do you sometimes just go for the steroids if the clinical picture is typical, let's say?
Yeah, indeed, we usually try to go for a kidney biopsy, but sometimes we cannot do that. Why? Because we are usually facing frail elderly patients, which are the ones that receive more polypharmacy, which are the ones that receive more drugs. So you cannot know really what's going on and which is the causative agent. And sometimes you can just not perform the kidney biopsy. In those cases, I think that you should go for steroids or I mean, the gold standard is to perform a kidney biopsy, and we should all aim to go for that. But in those cases that it is not possible, I would suggest starting glucocorticosteroids.
Yeah. And it's a pretty short term treatment, right? 2 to 3 months, as you've
Yeah.
alluded. Yeah. So it's not start high and then taper quickly, I guess. So how about follow up? Let's say that you have given steroids. Let's say that you have been successful. You have an offending drug that you think might be the reason, but you don't have the test, so you're not quite sure. Sometimes when you stop steroids, the kidney function worsens again and transitions into a kind of chronic tubulointerstitial nephritis. So, how often do you think we should follow up these patients after we've treated them with steroids? And if it transitions into chronic, what would you do then? Give steroids again, or maybe start some kind of steroid sparing treatment? How would you react to a chronification of tubulointerstitial nephritis?
Yeah, I think that's a very important aspect. I think that there are different forms of so-called chronic tubulointerstitial nephritis, but in those cases that we have patients with a partial recovery, then we should follow these patients as other patients that has have an episode of acute kidney injury and have chronic kidney disease 2 or 3 times per year, depending on the CKD stage the patient have. But I also think that patients that have an experience of fully recovery should also be followed, perhaps once per year or one every 2 years, because sometimes in the long term, it is known that if you have had one episode of acute kidney injury, you may have a CKD in the future. And I think that is also useful to follow them. For those patients that perhaps they have not fully recovered their kidney function and you're still in the acute kidney injury, like perhaps you should use other drugs, such as, for example, mycophenolate. There are some cases in which mycophenolate has been used and it was helpful. And I think that perhaps it deserves a try.
Mm. Yeah, we've used that also on occasion. Yeah. Well, you can find the odd patient where you think the drug is the reason, but actually, in time, you'll find that this was a silent Crohn's disease, something like that, which can also manifest as seen. So, yeah, it's always I always wonder how long we need to follow them up. Another interesting thing is uveitis, so the inflammation of the eye, which is relatively common in idiopathic teen, constituting the Tinu syndrome, and is often quite asymptomatic, not a lot of pain. Maybe you only notice the vision changing when it's really advanced. So, should all patients with undescribed or idiopathic tin be referred to an ophthalmologist? Do you do that? Do you do that regularly?
Well, it is a very uncommon condition. I mean, the incidence is around 2% of all uveitis cases, so really very, very low.
Mm.
And I think that it might reflect that we are underdiagnosing these patients, because I have also read that 98% of all the TINU patients were diagnosed by the ophthalmologist and not
Oh,
by the nephrologist.
oh, really? That's
So
bad.
yeah, I think that's really bad.
That's really bad.
And I think that if I would recommend referring our patients that have an idiopathic TIN syndrome to the ophthalmologist and check for TINU syndrome. I guess that it's not very common condition, but some of the cases maybe not diagnosed.
Yeah. And it's as far as my friends ophthalmologists say, it's pretty bad when you don't treat it for a long time.
Exactly. Yeah.
Yeah, that's great. That's great. Do you have anything else to add that I haven't asked? Something like final take home message you would want to share with us?
Yeah.
This aside from talk to your allergologist, if you can do the timidine test, the lymphocyte transformation test. Aside from that,
Yeah, I will invite people to think about this disease to think when there is an acute kidney injury to think about this disease, because sometimes we only rely on blood tests and serologies, and we sometimes neglect this syndrome because there is not anything on the blood test will provide you information. So I think it's very helpful to talk to your patient, really ask him or her what has he or she been taking during the last months. I think that's the most helpful tool we have.
Yeah. And check the urine, right?
Exactly, yeah.
That's also sometimes very revealing. I don't know if you do this in how much you do this in Madrid, but we regularly check for alpha-1 microglobulin, which is indicative of tubular proteinuria, and that's quite helpful. If you have low-grade albuminuria and a lot of alpha-1 microglobulin, that's always suspicious for a tubulointerstitial disease.
There were very cool biomarkers like that have been also published. The one CXCL9, which was really, really nice and cool to diagnose this disease, but still we don't have that into the clinic.
Yeah, sure. All right, great. So the final question is more about you than Tin. We like to know our guests a little bit, and the answers were very interesting in a lot of cases. And the question is, which book, two songs, and luxury item would you, Beatriz, take to a desert island? The
I
Canary
think
Islands, perhaps, or
perhaps that's not the desert, I have to say, but
it's not so desert. It's not deserted. Yeah, you're right.
but
I've never been there. Only seen the photos.
you have to come. But well, you saved the most difficult question for the end.
Yes, we like to do that.
Yes, I would recommend as a book 100 Years of Solitude. It is a work, it is written by Gabriel García Márquez. And after all, on a desert islands, you will have plenty of time to get lost in the family because it talks all about a family
Yeah,
and untangle all the genealogies that it provides. And for the songs, I think that I Will Survive is the perfect thing for this island
definitely.
because it talks about resilience. And I would also recommend some Spanish music. La Salvación is from a Spanish group, which is called Art de Bogotá, which I'm really obsessed with them. For the luxury item, I was thinking about practical things, medicines, food, whatever. But what truly comes from the bottom of my heart is a good bed. I
Mm,
mean, I love sleeping and I couldn't
mm,
survive without proper rest. And being well rested in an island would make everything else so much easier.
yeah, I can relate to that a lot. Yeah, I have to tell you, you're not the first person who has chosen 100 Years of Solitude. We've had that book chosen before. Have you seen the series
Yeah, I have
on
seen.
Netflix, I believe?
Yeah, I have seen the series, but of course, I should recommend you to read through the book
Yeah,
because it's
sure.
impressive.
It's pretty complicated, the book, but
Yeah,
I like it because I like the weird kind of stuff.
you will have the
I
time on a desert island on the
Yeah,
Canary Islands.
exactly. That one makes sense in the desert island. Okay, well, Beatriz, thank you very much. I hope that our listeners are now more tin aware than they were before, and hopefully we can all get this interesting lymphocyte transformation test running, so we don't need to tell our patients they can't take a medication that they could take. Thank you very much. I hope you had a great time with us, and we'll meet you at another Congress, I guess.
Thank you.
Yeah. Bye bye.